Hello, my name is Frank Pitts. I'm an architect in Troy, New York, from Troy, New York in the United States, and I've had the pleasure of doing psychiatric hospital design and consultation throughout the United States and Canada over the last 25 years. I've been invited today to talk about trends that are influencing the design of psychiatric hospitals. An interesting thing happened in medicine about 10-15 years ago. We all began, and you all began, to understand that it wasn't sufficient to treat the illness. It was important to treat the patient, and to see the patient first and foremost as an individual who had an illness. This has had significant implications for the practice of medicine. Indeed, it's having significant implications for the practice of psychiatry. It has enormous implications for architects, because it asks that architects solve the fundamental human problem of what it's like to house people who come to live and work with each other for an extended period of time, solve that problem first and foremost, and then focus on the illness. What we're finding is that by solving the fundamental human problem in a partnership with clinicians, we're able to actually build environments that allow clinicians to manage the milieu, to use the milieu as a part of the treatment regime, and that there is indeed a significant and profound relationship between therapeutic programs and environment. This is probably the central touchstone of the fundamental change in the design of psychiatric hospitals over the last 20 years. It has led to a conclusion that the best setting for patients is in a private bedroom, which begins to ask some very interesting questions of what type of private bedroom and where should the bathroom be? Should it be on the outside? Should it be on the inside? Should it be between the rooms? It has enormous implications in terms of ability to see into the room, control of the bathroom by staff, implications in terms of indeed of how long hallways are and how big a hospital is. It's a major sea change. There is rarely a psychiatric hospital in the United States and Canada today that's not begun with a thought towards developing as many private bedrooms as possible. It's not unusual to begin a project, and these are drawings from an exploration that we did on new Specialized Mental Health Center a couple of months ago in London, to begin a project with a conversation about how big should the unit be, and how big should the subclusters be, and therefore how many subclusters should there be. And these are diagrams that we drew for consideration and for conversation around where's the sweet spot for that institution. And every institution needs to ask themselves the same question. What's the appropriate size of unit, typically? And what's the appropriate size and number of subclusters that make that unit? And then, how best do we arrange them so that patients have privacy and autonomy, and staff still has the opportunity to supervise and to provide services efficiently and economically. At the end of those kinds of conversations, the inpatient unit is then designed for that hospital based on the answers that are appropriate for that hospital. The treatment areas have been decanted, and they've been decanted for a couple of reasons. And the first is to make the inpatient units more residential. But the second, more profoundly important reason comes out of a recognition of what a treatment program might be. And it's the beginning of a conversation of how do we accommodate a changing length of stay. As the average length of stay decreases, it becomes increasingly important that patients have access to programs off of the inpatient units for clinicians to be able to assess whether a patient is able to migrate across boundaries, return to the community. And basically what we're trying to do is to design a world in the inpatient unit and in the hospital as a whole that allows a patient to test their own ability to move beyond borders, and for a clinician to test and assess those same conditions. And so the two conditions are actually mutually reinforcing each other. On the one hand, we're decanting the residential areas in order to make them more residential. On the other, we're now beginning to be able to create zones of activity that heretofore had not existed in the hospital. You'll hear us talk about this as houses and neighborhoods and downtowns. So this is a diagram for a hospital in St. Thomas in Western Ontario. And we're going to see, first of all, these houses, the subclusters that are sitting to the left They have a lovely view from all of the bedrooms into the woods. And then to the right of those, we have a neighborhood. The neighborhood consists of the clinical offices for the clinicians who are serving the patients that live in those houses. It provides the group rooms, the consult rooms, the activity rooms that ordinarily would have been on the inpatient unit. But by locating them here just outside of the inpatient unit, they're still within the span of control of the direct care staff, but provide an opportunity for a patient to leave an inpatient unit to go to another place without the need for escort and still with a high degree of security where they can receive clinical programming. By sharing neighborhoods between and among units, the diversity of clinical care that becomes available to every patient is increased. And then finally in this model is the downtown. What the downtown is those things that are singular to the hospital as a whole. The gymnasium, the library, the bank, the cafe. The exercise room, the large exercise room, those sorts of things that the whole hospital shares. So the model that's emerged in terms of care is house, neighborhood, and downtown. Probably the first place that the model was built was at the Rochester Psychiatric Center, which is illustrated here. The houses are the four L-shaped elements that you see at the back. At the top of the picture, the neighborhood is the bar that links the four houses. The downtown is the part of the building that's at the lower part of the picture. And all of it is designed around a rather large courtyard. Another profound change that's happening in the conception of the psychiatric hospital is the intersection between a change in treatment modalities and the research imperative. We're increasingly seeing these hospitals move from being a place where people are stabilized prior to return to community to a place where patients actually are actively treated, where skills are regained, where increasingly procedures are happening. If procedures are happening more regularly, as they are at many hospitals, then the movement from the inpatient room to the place of procedure becomes far more important than it ever has been in a psychiatric hospital. So we're seeing significant volumes in ECT, increasing volumes in transcranial magnetic stimulation. There's going to be an interesting combat there in terms of which procedure is going to be the one that over the long term turns out to be the most efficacious. We're seeing increased use of diagnostic imaging equipment as a part of the assessment program. Now, admittedly, today, that's mostly in facilities that are doing research. But as early diagnosis becomes more important, access to imaging equipment is going to be important to the design of these hospitals. And it's impossible for us to think of one of these hospitals without thinking about where that equipment might go. Increasingly, we're finding that people are building research base into pure psychiatric hospitals. This is a rendering for the proposed Center for Mountain Health Services in Hamilton, Ontario. Now, and this is a place where this hospital is fundamentally different from what we've experienced in the past and a harbinger of what we're beginning to see at Royal Ottawa and other hospitals. And that's the integration of basic science into the inpatient and outpatient setting. This is a hospital where there's over 70,000 square feet of wet lab and dry lab space as an adjunct to a series of clinical lab spaces that are embedded in the outpatient programs. The decision here was to make a whole floor of the building, laminate a whole floor of the labs into a whole floor of the building, directly connected to the whole rest of the hospital, so that an outpatient coming to the dry lab space for a clinical intervention, for him it feels just like going to an outpatient program. The other advantages are the mix between clinical staff and research staff that happen where they share the same elevators, share the same library, share the same cafeteria, where they're proximate to each other. Now, this interesting evolution of how we think about the hospital and the convergence of psychiatry and neurology has, as we've talked, fundamentally changed what goes on in the hospital and what's likely to go on in the hospital. It actually promises the possibility that active treatment and early diagnosis might do away with a significant part of the work that's traditionally been done in the hospital. And one of the great challenges of designing one of these today is to be humble enough to recognize that possibility. That 100 years ago, we built loads of tuberculosis asylum. And the minute that somebody figured out what caused tuberculosis and treated it actively, the reason for those asylums disappeared. And so another great challenge is to design these hospitals flexibly. And using the Hillside Hospital's master plan as an example, it's a project that's designed with, I'd say, 5 types of flexibility, allowing for future uses and accommodating future change. And so, you're launching this endeavor at a really interesting time, both for architecture and for mental health. It's a time when architects are reimagining actively what this building type might be, what it should be. And you've witnessed in this slideshow that it can be very, very many things. We should come to it with no preconceived notions. But simultaneously, it's a time where you, as practitioners and clinicians and researchers, are reinventing how you care for patients and anticipating a fundamentally different way of caring for patients in future. And at the intersection of those two tendencies lies a wonderful opportunity and a great adventure. And I thank you very much for inviting me to come to talk to you about how others have been thinking about that same adventure.